So first, I want to thank Marav and all of you for inviting me. And I assume most of you are Marav's patients, so you're very fortunate to have such a talented physician taking care of you. Just so you know who I am, that we have one of the largest myeloma programs in the country. We've been involved in the approval process for basically all of the drugs that are used in myeloma right now. So we have been fortunate to have the opportunity to be major participants in clinical trials, which is what I think is which is one of the most important things for us to do and for you to participate, because we know that that clinical trials are what changed the world for all patients, but particularly for multiple myeloma patients. So this slide is something that I'm sure you sort of all understand, but the way we treat patients with multiple myeloma is to give them therapy to control their disease, but at the same time make a decision about whether patients are candidates for stem cell transplants or not. So we have patients who we consider stem cell transplant candidates, and we have patients who we don't consider stem cell transplants. And the definition is different in different parts of the world, number one, and in different hospitals in similar parts of the world. I'm a big believer in stem cell transplants. So most of my patients, up to the age of 80, we transplant. This is a very important part of the decision-making process in the beginning. But in any case, what happens is that most of the time today, we're successful. When I first started taking care of myeloma patients, only in about half of the patients could we get the disease to go down at all. Today, it's not 100%, but it's between 95 and 100% of patients we can make the disease go down. The problem is, how long will it stay down, and what do we do when it starts to come back up again? And that's what I'm going to talk to you about today. So everybody understands the definitions of relapse disease and refractory disease. So if you have started your treatment for multiple, you're going to stand here so you can answer my questions. So when you start getting treated in the beginning, and as we said, most patients will have a response. The disease will go down. So relapse is when that response ends and the disease starts to come back up. Refractory is that you're receiving therapy, and despite the fact that you're receiving therapy, the disease is going up. So you can be relapsed or refractory, or relapsed and refractory. So everybody understands now? So we're talking today about treating patients who are relapsed and relapsed refractory. So that's what we're going to talk about. How do we know that somebody is relapsing? Does anybody want to guess? Here we have some choices. So how do we, as the doctors, know that the patient's disease is coming back? What tells us the most frequently? Does anybody have a guess as to which of these things is most common? Is it the blood test? Is it the anemia?
נכון, אבל מה הכי שכיח מהסטטיסטיקה? איך המחלה... מה?
It's actually just the blood test. Most of the time, the patient doesn't know that they're relapsing. So in the old days, when we didn't have good blood tests, it used to be anemia or pain or kidney problems or calcium. But today, most of the time, it's going to be the doctor who tells the patient that they're relapsing and not the patient telling the doctor. And that's the goal, for us to decide to treat before the patient is getting hurt.
Okay.
So it's only about 30% of the patients that it will be the patient telling us that the patient is suffering again from the disease. 70% of the time, it's the blood tests that tell us. The patient doesn't know that anything's going bad. So it's now a very difficult question as to when we should treat. If it's just a biochemical thing, do we treat everybody as soon as they relapse, or do we wait for something worse to happen? Now, the problem with waiting is if we wait for the patient to get sick, sometimes you can't take that back. If it's that you get a hole in your bone and the bone breaks, then you have to suffer with the consequences of that. If it's that your kidney function gets worse, maybe we can make it better, but maybe we can't make it better. So it's a very difficult question as to when is the right time to start treating people. And that's why it's very important to have a good doctor taking care of you, because you don't want to wait, but you also don't want to treat people when their life is good and they're running around and they're going to work and their life is a normal life. When you start to treat them, the drugs all have side effects. So this is the biggest problem that we have. I'm sure it's the biggest problem for Dr. Liebe. It's certainly the biggest problem for me, is when to decide. And there's not a right answer to that. It's a very, very difficult question. And sometimes the patient has to be part of that conversation about, no, I want to start early, or no, leave me alone. I want to go to work. I want to do things. You tell me when is the last moment that I can be treated. Everybody understands? Yeah. So then how do we choose the treatment? And there are different factors that go into it. Sometimes it is the myeloma itself that tells us, what choices we should make. If we know that the myeloma is aggressive myeloma, is very mean myeloma, based on things that we know from the cancer cells themselves, that tells us something about which choices we make. Sometimes it is about the patient themselves. If the patient is young, we may make one choice. If the patient is old, we may make another choice. If the patient has diabetes and giving steroids is going to be very difficult, well, maybe we would choose a stem cell transplant that doesn't, that ends. It doesn't have a lot of therapy, so that we don't have to deal with some of the complications of our therapy. And then, as important as anything, is if you had bad side effects from earlier therapy, we have to keep that in mind as we make the decisions about subsequent therapy. And this is just a different way to look at that. So disease-related, prior treatment-related, and patient-related. And what's good for one patient might not be good for another patient. And again, this is why it's important to be taken care of by doctors who understand your disease, and not doctors who do a little bit of this and a little bit of that. That it's a very difficult disease to put all these things together. So no one has to remember this. This isn't going to be a test. But when I first started taking care of multiple myeloma, Dr. Liebe wasn't born yet then. We had very few choices. The only drugs that worked were a pill called Alkeran and steroids, like prednisone or dexamethasone. Those were the only drugs that worked. And now, over the last 30, 40 years, it has changed a lot. And while it has made the decisions much more complicated, it also means that patients do much better. So when I first started taking care of myeloma patients, the average survival for a myeloma patient was 18 months. So today, 50% of my patients that were diagnosed 10 years ago are still alive. So that was diagnosed 10 years ago. So today is much better world than it was, well, much better myeloma world. I wouldn't say it was a much better world. That today we have an enormous number of new drugs just in the last couple of years, and more new things are going to come along very quickly. So 10 years ago, the median survival was 10 years. Today, the median survival is, I don't know, it's certainly going to be much better than that. So it's a very hopeful time for patients with myeloma. And it's because of all of this. You know, here, these new drugs. And actually, of all the drugs that have come along since I started taking care of myeloma patients, the most important one is this one. So you know what bisphosphonates are? So those, you know, you talk about all of these fancy new drugs that we have, but the most important ones are actually Zometa and Iridia, because they completely changed what myeloma is, and they're important. So remember those drugs. So I showed you this, but what I want to show you here is this is where we are right now. These are just some, not all, of the drugs that are being studied right now that have a good chance of being important for treating people with multiple myeloma. So this is a very hopeful time for multiple myeloma patients. So we talked about when did you relapse from your initial therapy? If it was more than 6 months, if it was less than 6 months, you probably don't want to use the same drugs over again. You might use some of the same drugs, but you better use them in a different combination. If it was more than 6 months, then there's a good chance that the therapies that you got previously will work again. And depending on why you started, the side effects is why you stopped. Side effects, because it was the plan, you might do very well. It's just starting the same drugs that you had seen previously. So again, I don't want to confuse everybody, but we have many different classes of drugs that have been approved for myeloma now. Some work very well, some don't work so well. Some are available everywhere, some are not available everywhere. So the point of this is that we have a lot of choices, and that for each of those kinds of drugs that we were talking about, and again, this is not so everybody should remember all of these things, but just taking that handful of drugs that we have, look at all the combinations that we can use. And for some patients, one of these is going to be better. For other patients, another of these are better. But the point that I'm making is it's very confusing, but it's also very positive time for patients with multiple myeloma in terms of having choices that we can make. So my favorite subject is to talk about clinical trials. Everybody understands what a clinical trial is? So we have many different kinds of clinical trials. The earliest kind of clinical trial are what we call phase 1 trials. And those are trials usually with either new drugs or new combinations of drugs, and that the goal is not about what is the response rate going to be. It is about the side effects of those drugs, and can we use this drug or combination safely. Those are phase 1 drugs. And generally, those are phase 1 trials. And generally, we don't do phase 1 trials in patients who have other really good choices. Phase 2 trials come after that. We've figured out that the drug can be given safely. We have some hint that it will work in a particular disease. And so now we start to treat patients under better circumstances and learn more about the value of this combination. And then once we have that kind of information, we do phase 3 clinical trials. And that means we compare a new way of treating patients with an old way of treating patients. And then phase 4 clinical trials are clinical trials that are done after drugs are approved, trying to optimize the use of those drugs. So everybody gets worried about whether they should participate in a clinical trial. But it should be understood, particularly in oncology patients, that we don't do trials in which we don't give the patient therapy that we think has a good chance of working. So people who sometimes are scared to participate in clinical trials because they're worried that they're not going to get the drug that they think that they're going to get. But the principle in oncology is that when we do trials that compare two things, both arms of that trial have to be legitimate, good treatments for those patients. So it's not something to be scared about in that kind of regard.
אני רוצה רק להדגיש את זה, אז מה שפרופסור סיגל אומר, וזו נקודה מאוד חשובה, ניסויים קליניים באונקולוגיה והמטולוגיה, אין פלצבו. בדרך כלל אתה נותן את התרופה רגילה מול תרופה חדשה, זאת אומרת אין מצב שהחולה לא יקבל את הטיפול.
So one of the things that everybody should understand is that the outcome for patients with multiple myeloma, the outcome for patients with cancers in general, is better in institutions that do a lot of clinical trials than in institutions that don't do a lot of clinical trials. So part of that is because these drugs help the patient. Part of that reason is obviously that the physicians who are doing those clinical trials tend to be much more experienced physicians with those particular kinds of diseases. But the point is that clinical trials are very important, and the reason that my patients, when I first started taking care of myeloma patients, only had a survival of 18 months, and the patients 10 years ago now have a survival of 10 years, and the reason that patients treated today will do better than that is all because of clinical trials. So there's many reasons that people don't do it, but the bottom line is if you trust your doctor and you know that your doctor loves you, that these are the kinds of conversations that you should have, because it's very important for you yourselves, but it's also very important for other myeloma patients around the world, and also other myeloma patients here in Israel. I'm not going to go through all these details, but the bottom line is, if you have the opportunity to participate in a clinical trial, it's an important conversation to have with your care team, not just your doctor, but the nurses and the clinical trial specialists who work as part of the team, so that you can make the best choices that you can. So today we've made so many advances in treating myeloma. Not so long ago, we were just desperate for drugs that worked at all. We didn't have very many drugs that worked at all. But now we can start to ask questions about not just does a drug work, does a combination work, but what kind of therapies do patients feel better on? What kind of therapies allow them to work? What kind of therapies allow them to feel better and not have the side effects? So the fact that we're asking these kind of questions is a reflection of how much we've learned about taking care of patients with multiple myeloma. And there's all kinds of tools that we have, and I'm just going to, there are all kinds of tools that we have to ask questions of myeloma patients so that we understand what it is that is important to them. That sometimes it's to live absolutely as long as you can. Sometimes it's to be able to go to work. Sometimes it's to be able to, to button your shirt and not have your fingers bother you. So there are many things that are important, and it isn't the same things that are important to each patient. So you guys have to teach us as much as we have to teach you. So this is just a list of some of the drugs that we have, but the part that patients are sort of most excited about these days are what we call immunotherapies. Now, there are a lot of things that we could call immunotherapies, but we have some very exciting drugs, and I'm going to talk a little bit about some of them. This is the newest drug to be approved in the United States, not approved in Israel right now, right? It's a difficult drug. We're just starting to learn how to use it. Hopefully, this will make a difference in patients with multiple myeloma. It's not something that is probably worth talking about now. There are other new drugs that are not great drugs for treating all myeloma patients, but are good for treating some very specific myeloma patients. So venetoclax is a drug that I wouldn't call a great myeloma drug, but there is a group, maybe 10 or 15% of patients with myeloma, in which it is a very good drug. So as we start to understand more about the disease, we're going to find more and more drugs that are good for this patient, but not for that patient. And that's going to be very important, because when we give patients drugs that don't work, it makes their lives worse and doesn't make their life better. So one of the things that we still need to learn, even with the drugs that we have, is which drugs are most likely to work in which patients. And that's something that we're starting to learn now. This is just a list of a lot of drugs that are in clinical trials right now. This is not important for anybody to know, but it's important to see, because this is why we all have reasons to be hopeful, no matter where we are in the course of our treatment. So does everybody understand what monoclonal antibodies are?
אתם מבינים מה זה נוגדן מונוקלונלי? אנחנו מדברים על תרופות כמו דארטומומם שחלקכם כבר מכירים. אתם יודעים מה זה נוגדן מונוקלונלי, או שרוצים הסבר מה זה בכלל באופן כללי?
זה ביולוגי, לא?
זה ביולוגי.
It's one kind of biology.
No, because they compare to chemotherapy,
Yeah.
not chemotherapy.
But many of the drugs that we use in myeloma are not like chemotherapy. I mean, none of them. Revlimid, Velcade, Cytoxin, cyclophosphamide is a chemotherapy. But a lot of the drugs that we use in myeloma aren't chemotherapy like breast cancer patients get or leukemia patients get. So we're lucky we have some. But monoclonal antibodies, we just started using them, and you're going to see that there's going to be a whole series of new monoclonal antibodies that come soon. So perhaps no fighting children. But the real immunologic drugs are the part that is perhaps the most exciting and the stuff that we're just starting to do. This includes new monoclonal antibodies. We have antibodies that we're engineering so that they work better. We have vaccines that are being tested to try and boost the patient's immune system. And then we have the ability to take immune cells out of the patients, change them, and then put them back into the patients. And all of these are very exciting things. And I'm not going to talk about daratumumab. So daratumumab, you know daratumumab is what we would call a naked antibody. So we have now new antibodies that have poisons attached to them, and the antibody brings the poison to the cancer cell, and that poison then can kill the cancer cell. And then we have bodies that can change the way our immune system works so that we can get our immune system to kill the cancer cell. So they're not antibodies that directly kill the cancer cell, but they're antibodies that trick our immune system into killing the cancer cell. Elotuzumab, I'm not going to talk about. No. Should I talk about bispecific antibodies other than saying what I said?
I think you'll say it already.
Yeah. So I talked about antibodies that can trick the immune system. So what we can do is we can take an antibody, sort of like daratumumab, that binds to the cancer cell, and then on the back end of it, we can attach another antibody that will pull immune cells on top of the cancer cell so that immune cell will then kill the cancer. So this is a new thing that is going on in the myeloma world. And there's a whole bunch of them that are being studied. I told you about ones that have a toxin added to them, and these are in clinical trials. But perhaps the most exciting one is what we call CAR T cells. So we all have cells in our body that can kill cancer cells. The problem is that they get tired after a while and they stop doing that. And is there anything that we can do to sort of rev them up again? And one of the things that we can do is to engineer them. We can put in a motor that both brings them to the cancer cell and then turns these cells on so that they get very angry at the cancer cell and can kill it. And so that's what CAR T cells are. And there are companies here in Israel that are doing research on this kind of thing. And so you're going to see this become available. This is all an experiment. None of this is standard therapy right now. But what we can do is we can remove some of your immune cells from your body. We can take them out. We can put them in, bring them into the laboratory. We can put a special gene into those cells that makes them very, very angry at myeloma cells specifically. And then we can take those cells that we've grown, give them back to the patient, and then these cells will kill the cancer. And so we know that this works in lymphomas, and this kind of therapy is commercially available in lymphomas, but not yet in myeloma. But we know that it works in myeloma. We don't know how well it works yet, but we know that it works in myeloma. So hopefully you'll see over the next year or two that this kind of therapy becomes available for myeloma patients. So that's what CAR T cells are. And this is just a list of a few of the clinical trials that are going on now. Most of this is happening in the United States, but it will be happening in other parts of the world as well. And I quoted not about myeloma, but there are 580, I think it was, different CAR T cell studies going on in various diseases. So you're going to see this become important in myeloma. You're going to see it become important in people with other kinds of cancers, and you're going to see it become important in people even with diseases that are not cancers. So this is something that is going to change medicine. So we already know that this kind of stuff works. Now we're trying to figure out how to make it work better. And hopefully this will be something that benefits all of us. So everyone is very excited about CAR T cells, but we don't really know if it's ready to really change the way that we think about myeloma. And we have lots of other kinds of drugs that we're trying to develop. There are new kinds of clinical trials that are just starting to be done in multiple myeloma. So I don't know how many people in the room are multiple myeloma patients, but if there are 20 or 30, everyone's cancer is different. And one of the differences between myeloma and other cancers is that when we check the genes of myeloma patients, everybody's different. You know, there are some cancers in which the mutations are pretty common. That there are certain kinds of leukemia where everyone has the exact same mutation, and you can develop a drug that targets that mutation. And even some cancers like breast cancer and colon cancer, it's the same group of mutations in all of the patients. But in myeloma, every patient is different. There are no mutations that occur in more than about 5% of myeloma patients. So each patient is different. Should we be using the same drugs in every patient? No, clearly we shouldn't, but that's what we do. So we're now starting to have clinical trials that are aimed at if you have this mutation, or this mutation, or this mutation, or this mutation, that you get a different drug. And that those drugs are aimed at the specific mutation that individual myeloma patient has. So far, none of this is successful. None of this is proven. But the point being that we're going to get much smarter about myeloma, and that in the near future, tomorrow, next year, in the next 10 years, and myeloma is now a disease that you can talk about 10 years. We couldn't do that before. You're going to see that we're going to have therapies that are good for your cancer and not for your cancer, and therapies are going to be better because of that, and the side effects will be less because of that. So we have all kinds of new technologies that are going to allow us to manipulate the genes and do all kinds of things. And one day the world is going to be a different place for lots of reasons, but you're going to see that in myeloma the world is going to continue to change fairly quickly. So I told you that we're now starting to do clinical trials that are about whether we can make the patients feel better, not just make them do better over the long term, control their disease, but we just finished a study in our institution because we thought that patients who went through stem cell transplants feel worse after their stem cell transplant than for patients who didn't go through that kind of therapy. Turns out that it's not true, that the quality of life that patients report having gone through stem cell transplants is actually better than the quality of life for similar patients who don't go through stem cell transplants. And so we start to ask patients questions about what's important to them and what's what it is that their goals are, rather than it all being about what's the best thing that we can do for their cancer. So that's it. The end.